move to a presentation by Dr. Briana Costello, who will be speaking about female-specific dilemmas in diagnosis and treatments of cardiac conditions. Welcome, Dr. Costello.
Thank you so much, everyone, for having me. It's a real honor to be able to be with you guys here at Women Heart and everyone who's here on the Zoom call. Barbara, that was a great presentation, and I can certainly underscore that I see what you're seeing. The palpitations in patients is real, and just, at the beginning, we didn't know what to make of all of this after COVID, but the palpitations were so frequent and certainly contributed or attributed a lot to anxiety after COVID until people really started digging in. And just from my personal experience, and I'm sure many of you have similar experiences, putting monitors on these patients and validating that, yes, your symptoms are real and you actually are having tachycardia, or, this is an elevation from your baseline heart rate, is actually some sort of therapy for a lot of these patients so that they're validated. They just don't think they're crazy or anxious or worried. So thank you, Barbara. That's really awesome what you guys are doing at NYU Langone. So switching gears a little bit, I'm going to talk a little more broadly about female-specific dilemmas in diagnosis and treatment of cardiac conditions. Touch a little bit on some things that have already been spoken about today, but hopefully highlight the important aspects of cardiac care for women. Next slide. So just backing it up just a minute, I'm a general and interventional cardiologist here at Texas Heart Institute in the Texas Heart Medical Group. So interventional cardiology is something that I hold near and dear to my heart. And as a female in particular, I find it to be near and dear to my heart because we have to keep advocating for women to have the same treatment and same recognition of acute coronary syndromes as our male counterparts. So a fun little history lesson that I'll waste no time on. In 1912, James Herrick went to Rush University Medical College or worked there, and I did my internal medicine training years ago there. So he's also close to me. He described coronary thrombosis and myocardial infarction initially in JAMA, and people didn't believe him, really. They didn't actually trust what he was saying, but it's real. Obviously, we know now. Fast forward to 1929, Dr. Forsman performed the first cardiac cath, so went into his own vessels on himself, which was pretty remarkable. I think he got a Nobel Prize for that. In 1958, the first coronary angiogram was done by Dr. Soanes, and in 1977, Gruenzig fortunately performed the first percutaneous intervention. And here we are today, fixing heart attacks in men and women with coronary intervention and stents. Next slide. Oh, I'm sorry, I got it here. So what are my objectives today? I'm going to try to keep it brief, keep us on track here. So I want us to all kind of think about what biases that exist that may pose a barrier to healthcare delivery for women. And I know we've talked a lot about many of these today. How do cardiac conditions present differently among men and women? What cardiac conditions are specific to women and may often be overlooked, and we certainly talked about some of these. How are the outcomes different for women with heart disease, in particular myocardial infarction? And what are we doing to change cardiac care for women long term? So some things that many of us physicians, providers, care deliverers have heard. Heart attacks happen more often in men. We often hear that, especially as interventionalists, or women are just more anxious. So they feel like their heart, is having symptoms more than men. I'm laughing because I think this is just absurd that this is such a common thing to hear tossed around. In particular, postpartum for women, you just had a baby, you can't have a heart problem, or, oh, you just had a baby, you're overwhelmed, you're just tired. A lot of women I say, well, I was just told I was out of breath because I'm overweight. So blaming obesity for symptoms. And then, of course, everyone's favorite is, oh, you're a female, you're just anxious, you're not really having chest pain, or you're not having palpitations, it's just anxiety. All of these things exist, and it's clear. And if we can all acknowledge it, men and women, that we can treat women better long term. So I'm going to start with a little case. I have two case vignettes that I think are very interesting, just in my personal experience. I had a 30-ish-year-old female with no real past medical history came to me. She works in the medical field. She's actually a physician assistant. And she had increasing feelings of anxiety over the last few months. And she had an event at work. So she was feeling like, oh, maybe I just had a little PTSD from months prior. She was referred to her therapist, but she said, I've been going to my therapy and I like my therapy and I feel like mentally I'm doing better, but I still feel very anxious or feel like I have these palpitations. So we put a continuous monitor on her, a heart rate monitor. And I said, you know what? I don't know. We might find nothing. But at this point, you've gone through the hoops. You've addressed possible, is it anxiety? Sure, maybe, I don't know. But we should do a little more investigating. And her monitor looked a little something like this. This is not exactly hers. This is an example, but this is from a 2-week continuous monitor showing SVT at a very fast heart rate, as you can see. She was having multiple episodes of AV NRT every single day. So an SVT or supraventricular tachycardia at very fast heartbeat beats per minute, and simply underwent an ablation because she didn't want to take medicine. She was hopefully going to have a baby in the future, just wanted to deal with the arrhythmia and be done with it, had an ablation and is symptom-free. And she said, my anxiety seems to be cured. So that's one example of, listening to your patient. There's a great book, Every Patient Tells a Story. And sometimes your patients just tell you, look, there's something wrong and I'm telling you. So we just have to listen. Case 2 is a 50-year-old female who had a past medical history only of hypertension, but she's been fainting and feeling weak. And she presented to the emergency room. She had on her electrocardiogram, her EKG, a new left bundle, which to us interventionalists and cardiologists, can be a little bit of a red flag, and had some chest pressure. So I was on call. I took her to the cath lab, and her coronary arteries, her arteries were beautiful. Her CT of her brain plane was normal. So I said, this is a little bit odd. So at this point, people thought, maybe she's just anxious. Again, my favorite. Maybe she's just anxious and she's not really fainting. And her family said, no, I'm telling you, she passes out. So we pushed for her to get MRIs of her brain, neck, and MRAs, MR angiograms. She had, as you can see on the right to the screen here, her common carotids, both were occluded. Her left subclavian artery, which is, you can see down to on the right of the screen here, was severely stenosed, and her brain was being perfused by lonely vertebral arteries coming from the right. So she certainly was passing out, and she had more than just anxiety to explain why she was passing out. She went on to, next slide. Went on to have a stent of her left subclavian, left vertebral artery. So now she had 2 patent vertebral arteries, and she came to see me in the office feeling fabulous, hadn't fainted since she was discharged, and said, now can I go on my vacation to Florida? And I said, have at it. We're risk factor modifying her as well, because she certainly has underlying disease that had never been addressed, but she's feeling like $1 million. And again, just listening and not blaming, unfortunately, letting these women fall into a cycle of depression or anxiety or whatever can be life-changing for a patient. So just listening. Next slide. So case 3 to a million, I'm sure. We know that heart disease is the #1 killer of women. Many of these women, especially with cardiovascular disease, especially with myocardial infarction, are missed, literally missed. We, healthcare providers, we now know women don't always present the same, or we should know. But despite this, we still miss women with heart disease. So I'm so glad that the, Women Heart exists, and there are so many people that are willing to join the fight to, make this widely known and get women the best care they can for their heart disease. Next slide. So I'm going to break it down a little bit more. There was an excellent, a very interesting study, the Virgo study. It was an analysis of the Virgo study with myocardial infarction symptoms in women versus men. And women always, now they say, oh, but my symptoms, are they the same? Are they different? I heard they're different. And certainly this study helps us understand exactly what symptoms, how they might be different. So this was the largest prospective observational study to date of young women and men with acute heart attacks or acute myocardial infarction. There was 3,500. The men and women were age 18 to 55. They were hospitalized with their heart attack in 103 hospitals in the US and 24 hospitals in Spain. Next slide. Actually, let's stay here for a minute. I'm just going to go and say that the symptoms, these were interview symptoms. So patients were asked, do you have chest pain, jaw, neck pain, dizziness, indigestion? So as you can see, more men than women actually had just chest pain by a number, and it's significant. Jaw, neck, arm, and back pain, more common in women compared to men. So they didn't have perhaps maybe as much chest pain, but at these other atypical symptoms. Nausea, more common in women. Palpitations, more common in women. Again, our favorite that we like to hear, women just have palpitations, they're anxious. No, this is a very common, really common symptom in heart attack. Shortness of breath, more common in women. Fatigue and weakness, again, more common in women. So again, these atypical symptoms that we might not always associate with a heart attack, more present in women compared to men. Next slide. Unfortunately, what they found in this analysis was that women were less likely to receive emergent or urgent PCI, so percutaneous intervention, which is the life-saving or the myocardium heart muscle saving therapy that we deliver emergently when people are having heart attacks. They're more likely to have atypical chest pain, as we discussed, and they're more likely to have a delay from the onset of symptoms to presentation of greater than 6 hours. There was an excellent publication literally 2 days ago, I think end of June, I guess it just came out on the social media circuits where I find many of mine on Twitter, that showed and it confirmed that women were far more likely to have a delay in their percutaneous intervention or their life myocardial saving procedure than men. And on average, it was 10 minutes more of a delay to procedure than men. And in interventional world, that is a big deal because we count the minutes. So 10 minutes might not seem like a lot to some, but it's a lot when you have muscle of the heart dying. So again, time after time, we are illustrating that women are perhaps a little undertreated, underrecognized, underdiagnosed compared to our male counterparts. Next slide. So the facts again, heart disease, as we know, kills more than 1 in 3 women. It's much more likely to kill women than breast cancer. We're more likely to die from a heart attack than men. And there are cardiac diseases that affect women more than men, and those are often ignored. Next. So what are these more rare cardiac conditions, perhaps, or at least more underdiagnosed cardiac conditions that women suffer from more than men? Spontaneous coronary artery dissection, tongue twister. That is very female predominant. Interestingly, I had a very recent case with a male with what appears to be this disease. But anyway, recognizing that spontaneous coronary artery dissection is a disease of women is massive, especially in the interventional cardiology world, because we treat it very differently than we might treat someone who has normal heart attack from a normal disease process such as plaque rupture or plaque erosion. And so SCAD, or spontaneous coronary artery dissection, and it's important to diagnose, especially because then you screen them for fibromuscular dysplasia, and it's just important to educate people that it exists and to know what to look for. So that's something that I really try to focus on even with my colleagues who perhaps don't know as much about it. Syndrome X, of course, which is chest pain or angina without significant blockages identified on angiogram, more likely to affect women. It is real. There is reason for pain. It's just not the typical run-of-the-mill, you have blockages in the arteries kind of chest pain. Takotsubo cardiomyopathy, which you see over to the right, favoring females once again, unfortunately, which is stress-induced cardiomyopathy. more often in women who are a little elderly, stress-induced because it's often associated with stressful life situations or stressful life events. And it is a cardiomyopathy because it affects the heart function. So again, something that we miss perhaps or underdiagnose and affects women predominantly. Pregnancy-associated syndromes, which have been spoken about already, but very important, very pertinent for risk stratification. Very important to even know that they increase risk and often under discussed at appointments. The time limit, I get it. Sometimes you have 10 minutes, you want to discuss hypertension, cholesterol, diabetes. These things still need to be discussed, especially in women. Eclampsia, preeclampsia, peripartum cardiomyopathy, or knowing that it's on the differential if the postpartum woman comes short of breath. These are all very important things and often ignored or just missed at appointments. Next. So what are some outcome disparities? These are some of the most salient when I think about outcomes, what we need to really emphasize. In 1 year of a heart attack, a quarter of women and only 20% of men will die. So that's different and it's significant. Within 5 years of a first heart attack, 47% of women and 36% of men will have heart failure or suffer from a stroke. And often we see this in the studies or in prospective, studies of women and men in how they're treated after heart attack or after stroke. Women are more often not getting the same treatment or the correct treatment for prevention for future events. After percutaneous intervention or stenting or ballooning, if you have a heart attack, women are more often having bleeding complications in hospital, longer hospital stays, and more in hospital mortality. And again, that article that was just published again in the American Heart Association also revealed that women have a higher 30-day mortality than men after heart attacks, after STEMIs. So it's real, it's still happening, and despite our best efforts, it's still something we have to continue to work on. Next. So again, we have to just know our own risk factors, advocate for ourselves, know what your blood pressure goal should be, what it is, how your blood pressure is at home, the cholesterol levels, your family history. Talk about inactivity with patients, talk about inactivity with your friends, know the risks of hormone use. That's something that I actually see very often daily in the office. We did discussion of hormone use. Is it helpful? Is it beneficial? Is it harmful? And then, of course, pregnancy history. And many times you'll find women have no idea this is related at all to future events, preeclampsia or eclampsia, and they're shocked to know, but they, after they know, they feel a little bit empowered, like, okay, this is something I should carry with me in my, office visits to my other doctors. I didn't know that this was a risk factor. My blood pressure, I really need to get on top of it, or we can use it as a motivator. Next slide. So how do we promote this change? Again, Women Heart, wonderful, amazing, happy to be here. I'm so glad that you guys exist, and I look forward to collaborating more in the future. The American Heart Association with Go Red for Women, and heart centers for women all around the US and abroad. Here at Texas Heart Institute, you see down there is a picture of Dr. Coulter and myself. She mentored me long before I joined, and it's an honor to be with her. We have to continue working on sex-specific outcomes in medications and devices, particularly in my interventional field. I think this is very important. Women are not little men, so we need to continue on sex outcomes for devices. And then we need to continue educating providers and our patients about disparities so we can all work together to improve outcomes for women. Next slide. And last but not least, we have here at Texas Heart, we have a really fun registry that we've worked on called Houston Heart Reach. It's in our Center for Women's Heart and Vascular Health, and it's really a registry that you can find down there at that website at texasheart.org / Houston Heart Reach. And you can help us recruit women. If you guys want to spread the news on this, we would love to have more women involved in developing more registries that like many of yours, that exist to help women's outcomes improve over time. And again, thank you, Women Hard, and thank you everyone for being here. And I have learned so much from all of these speakers before me, and I appreciate that. And onward we go.